Dr. Kevin Wernli, welcome to the Physical Performance Show.
Thanks for having me, Brad. It's great to be here.
Geez, it's been a big few years for yourself, Kevin. Just graduating with your PhD at the start of this calendar year, 2022, completing your research work at the end of 2021. And what a huge and important topic you've delved into, that of back pain, lower back pain. I mean, I often say there's very few people from cradle to grave that don't experience some form of debilitating back pain throughout their lifespan.
Yeah, correct. Yeah, 80% of us will experience disabling back pain. It's the most disabling of all health conditions in terms of years lived with disability. And the problem doesn't seem to be slowing down or improving, which is a bit of a sad reality.
It doesn't seem to be slowing down or improving is in the trend.
Correct. Yeah. Sorry to start us off on a downer as well. It's the truth, the facts.
There's no dodging the truth, right? And the obvious follow-up question to that, Kevin, is why is that? Should we be seeing a downward trend?
Yeah, look, massive question, and there's bound to be lots and lots of different contributing factors. I suppose an aspect of that is the back pain in general, or the spine, has got quite a negative stigma around it. It's not like other body parts. Like if you injure your ankle or you injure sprain your wrist, or you pull your calf muscle, it's like, yeah, no worries. I've heard that joint or that structure, and it's going to be sore for a bit, but it's going to get better. This isn't going to be a debilitating long-term problem. But around low back pain, there's this higher threat and higher perceived vulnerability of, or if you get back pain, you've got it for life. And even before you even have back pain, there's all these messages and rules around. You've got to, keep your back straight, brace your core, be careful when you lift, be cautious, protect your back, keep your back straight. Even before we have pain, which can stimulate this sort of negative societal narrative around low back pain, so that if you do experience it, the amount of fear and threat is often a lot higher. And if we understand pain being related to threat or the perceived need to protect the body, which modern contemporary neuroscience would suggest, then you can see why we're in a bit of a recipe for potential disaster. We also are pretty quick to scan the low back pain, the low back. And, we know that when we scan the back, chances are we will find something on a scan that sounds scary, can potentially be painful, but usually isn't. But then that gets attributed to the cause of being the pain, and people are frightened of that. And there's big scary words: degeneration, bulging, herniation, protrusion, sequestration. All these spondyloarthropathy. So all these scary terms. So I suppose it creates a narrative of fear. And I think that's one aspect of why back pain is such a big problem, and it's a bit self-perpetuating. The more we try to put money on it, and I rattled off a stat that it's the most disabling thing in the world, health condition in the world. That probably doesn't help the scenario, but I think a lot of these factors combine to it being the one of the most, or the most disabling health condition. It's a really central part of human beings. If you have a sore hand or a sore ankle, you can kind of do most things and you're not too worried about stuff. But if you had a sore back, and I've had a few episodes of pretty severe pain as well in my back and in my neck and different parts of my body, when it's in your back, it kind of disrupts a lot of your life, and it can really take away the joy from lots of just daily activities and things that people find meaning in. So that probably increases the threat value of that as well.
Oh, gosh, so much there, Kevin, but so well surmised or summarized there. You use the word, it's so emotionally charged. It is such an emotional area. And in some ways, I'm pleased that as a physiotherapy student, I had a quite decent episode of lower back pain, which was discogenic in nature and lasted for quite a while, and was associated with an L5S1 disc protrusion. I recall doing a stretch and feeling it actually occur. And I was studying this at the time. Obviously, this was 2004 or 3, and the best available evidence at the time. And I was still so afraid, so fearful. I couldn't, and I had all my aspirations and dreams in front of me as a young male that seemed to just vanish instantly. And I think that experience for me is something I still draw on 16 years on in the clinical setting, where you can really empathize with people and understand this emotional, state that they're often in, and the catastrophizing that can happen and fear avoidance. I vowed to never bend sideways again because I was doing a yoga stretch.
Sure.
Which brings us fantastically into your research, Kevin.
Are you bending sideways again now, Brad?
You'd be very pleased to know I am. And
fantastic.
And actually, the second last patient in my clinical load today, a young surf life-saving girl with lower back pain, she came in and completely unprompted by some of the preliminary work I'd done in preparation to speak with yourself, Kevin, and look at your work. She said, I just feel more confident with my back. And I thought, oh, wow, Kevin's going to be really impressed with that.
That's awesome. And I think there was a lot of negative talk at the start of that conversation, or this conversation. We probably should talk about the reality is that although most people will experience an episode of debilitating back pain, most people also recover. It's pretty uncommon to not recover. It's only around, some studies would say 10, 20, 30%. But it is the minority. So most people will get better. And they'll get better. Doesn't matter what you do with them. You could do core exercises, you can do Pilates, you can do exercise, you can do relaxation. As long as you're giving them some sort of tools and not freaking them out too much, the natural trajectory is really positive, as it is for other injuries. Injuries heal. The majority, maybe all injuries will heal, and any pain that's persisting longer than kind of 3 months rough time period, that's a pretty well documented time frame for tissue healing. You've got to start asking questions around, what other factors are contributing here? And usually it's not to do with an issue in the tissue or damage to your structures. And it's more to do with other factors, maybe weaknesses or offloading patterns or avoidance patterns or beliefs or stress or sleep or lifestyle. A lot of different factors come into play when we're talking about persistent pain. And I should also preface, my research was in persistent pain, and non-specific low back pain as well. So things like a specific disc protrusion that's pressing on a nerve, or a fracture in your spine, or the specific pathologies that are rare, somewhere between 0 and 10%. That wasn't what I was researching. I was researching the other 90%, which is non-specific. We can't be confident in attributing a specific cause for that. So once those specific causes have been ruled out, that's when we're talking about this sort of research. So that's a couple important messages to talk about.
Am I correct in inferring there that greater than 3 months, you'd use a label of persistent pain?
Correct. Yeah, chronic or persistent pain. Yeah, typically they're around that 3 month time period, which is when it's tissue healing is quite a well documented phenomenon, and it pretty much follows a typical time course. And that's usually all wrapped up by 3 months.
So 3 months, anything beyond that, start looking further abroad, as you just said, Kevin, considering other factors.
Yeah. And even before, usually even before like acute pain, you can have acute pain that's from a traumatic injury, like potentially your yoga stretch, although the question might be there, how many times do we move and bend? Maybe that was the straw that broke the camel's back, and there was other factors going on. Who knows, right? It's really difficult to say. I've seen lots of patients who will have acute pain. They'll be sore for a day or 2 days or less than 3 months, so not chronic or persistent. But already in their story, you can start telling and hearing things that point you towards, okay, this is not a structural traumatic injury issue. This is more to do with this person. They've just told me that they've broken down crying, that they're going through a divorce, or, they're highly, highly stressed. They haven't been sleeping. They're looking after an elderly parent, or things like that. So then you start thinking, okay, this is a system response to protection to a perceived threat in their life, as opposed to, you haven't lifted a fridge or done a heavy deadlift that's close to your tissue tolerance. Something else is going on here. Let's explore that further.
And, you use that statement that pain is related to a perceived threat, a need to protect, or a perceived need to protect the body. Can you just break that down a little bit for someone listening in who may not have sort of, put the two and two together?
Totally.
Can you just share a little bit more around that, please, Kevin?
Yeah, I think what it comes down to is that our traditional understanding of pain was that it was related to tissue damage, actual tissue damage. So that if you had a little bit of tissue damage, you'd have a little bit of pain. And if you had a lot of tissue damage, you'd have a lot of pain. Now, the more kind of contemporary understanding, the more that we do work in this space, and this is not my work, this is work of lots of great people before me and before us, the more we sort of understand that, hey, there's so many things that influence pain. Context is really important. So, if you have, sometimes the example we use, if you're military and you're in a war and there's a IUD, explosive that goes off and you get shrapnel in your shoulder, but you could also die and you've got to get to a helicopter for safety, you're not going to experience pain in your shoulder at that moment. You're going to be focused on survival, that fight or flight response to get to the helicopter, to get to safety. And then eventually when you're in safety, you might then feel your shoulder after. Whereas if you're just walking and, I don't know, you have a traumatic injury to your shoulder, but you're in a safe environment, your life's not a threat, your system, your brain will prioritize, okay, well, your shoulder is bleeding and there's damage there, so I'm going to produce pain. So this gets into a little bit into the neurobiology, the understanding of how pain actually is created. And I suppose the key message, without delving into it deeper, which we can, is that we used to think it was all to do with an issue in your tissue or some damage to your tissues. But now we understand that there's a whole lot more processes that occur from when your system, your nociceptors or the receptors in your system notice a change in your periphery, which will then get that information will get relayed up to your brain, and your brain will decide on the context of where you're at, past experiences, your beliefs, what you've been told, inflammation levels, stress levels, sleep levels, so on and so forth, and then decide, okay, should I produce pain or should we dampen down that response? Should we modulate that response because we've got other things in our hierarchy that are more important? A couple of good examples of this that I often use with patients to explain this process, that pain doesn't necessarily equal damage, are things like pulling the cuticle off your thumb. So if you pull the little bit of the skin off your thumb, or you have a paper cut or something, is there much damage there? Not really, but it can be pretty bloody sore. So you have high pain, but not really that much damage. And on the converse side of that, I'm sure people would be familiar with these mystery bruises that just pop up. They might have hit their knee on a chair or kicked the side table or something, and they have these bruises that pop up and they're like, I don't actually have any recollection of how that got there or doing that specific action, but I've got clear evidence that there's tissue damage. There's internal bleeding that's causing that bruise, but it's not painful. I'm not more bothered by it. More examples are things like a headache. Headaches can be really painful. If you did a scan of your head when you have a headache, are you going to see any damage? Probably not. What causes a headache? Well, maybe it's stress, maybe it's low sleep, maybe it's not enough water, maybe your nutrition's poor, maybe you've got tight muscles in your neck, those sorts of different things. And then finally, probably another good one is phantom limb pain. People that experience pain in a limb that's not there. So after amputation, they might have ankle pain. After a leg amputation, they might have pain in their ankle that they used to be there, but it's no longer there. There's no way that you could have any sort of nociceptive input from that ankle, but you still feel that, and that's still a very real experience based on pathways and, if we want to get technical, neural networks and cortical matrices of that pain experience. And we call it a pain experience because it's a whole body kind of experience. It's not really that clear cut as related to where you feel the pain as being the issue. It's a bit more holistic and whole person than that.
And so you use the term pain experience as opposed to...
Good question. Maybe, I suppose pain experience kind of encompasses that whole emotional part of it as well. Like if we put people in a functional MRI and elicit physical pain and emotional pain, in a way it's sort of processed in the same way, not one specific part of your brain, but it lights up different areas, your amygdala, a few different kind of key processing areas. So I suppose I use the term pain experience because it kind of speaks towards that more whole encompassing process of pain rather than just pain in my knee or knee pain, I guess.
I think that's an important distinction. It's a pain experience versus back pain. I think that's nice. Kevin.
And I think it's also, sorry to interrupt, I think it's also, you're kind of validating the person there. You're a person first that has back pain. You're experiencing back pain. You are not your back pain, that's separating that identity.
That's powerful as well, isn't it? There's two maxims that I'll often get a patient to write down, Kevin, with back pain. And one is, I do not have a bad back. I have a normal back that is currently sore. And, even the most stoic, oftentimes male, will look at me with a quizzical face and be like, why am I writing this down? And then they sort of loosen up and have a bit of a laugh, which is always fun. And the other one is, like you've already stated there, pain does not equal damage. And it's just such a sticky, easy to remember maxim. And something so simple, it's just education, but it's also, I think, validating that we, as practitioners, we can understand people's natural concerns. So powerful.
Yeah, absolutely. And I think there's so many negative messages around there in the world around low backs, as we've sort of discussed already. So having these little maxims, as you talk about, that just kind of question those, I think are really powerful. And they make a person feel far more comfortable. So they de-threaten that whole experience. And pain is linked with threat. So if we can reduce threat, then we can reduce pain.
Yeah, gosh, beautiful. And I think everyone seems like they know someone that's had a really bad outcome with back pain. The neighbor that's got a bad back, the fellow co-worker that's been off work for a long time with a bad back. It's, it's almost a synonym. If you've got back pain, you've got a bad back.
Yeah, absolutely.
We're afraid of that, but what is a bad back?
Exactly. Yeah, totally. And I think that you speak to one of a couple of things. The podcast that I was involved in, Empowered Beyond Pain, our tagline was, is there more to pain than damage? Sort of asking that question, okay, you're experiencing pain for a long period of time. Most people think that's due to damage because that's what they've been told by their trusting health professional and well-intentioned, well-meaning health professional, or just by societal narratives. And then the other thing is that, a bad back doesn't necessarily mean you're going to have pain. And you can have pain with a pristine looking back on a scan and have high levels of pain. And you can have a terrible looking scan, including with things like nerve compressions, which we traditionally thought, okay, that's more likely to have pain, and you are more likely to have pain, but there's still, 5 to 6% of people that can have a disc herniation and nerve compression and not be aware of it. That speaks to that complexity of pain. Now, probably another important thing to mention here is that all pain is real. Even when we say, okay, maybe you don't have a bad back, that's not invalidating your pain experience at the moment. You still, you've come to me to see me with pain. You're not going to make that up. And very, very rarely there might be some cases of malingering and making things up in certain scenarios. But I mean, for the absolute vast majority, why would they come to see you if they're just making something up? So really important, I think, to validate the patient or the person that's sitting in front of you and say, hey, this is still real pain. It's just a little bit more complex than what we first thought it was. I'm not just saying your back is fine, it's healthy, it's safe, because they'll be like, well, it's hurting. That's probably an important message, and certainly something that I messed up heaps, and probably to a degree still do. But we're always getting better.
Yeah, it's such a great add-on. That is something that I tend to immediately say after it, but this is not diminishing the pain that you're experiencing, and just that acknowledgement that they are having that, as you say, pain experience, and it is very real. Still very threatening. Kevin, that's some really nice sort of landscape that you've explored there already. Let's jump into the PhD, the broad scope of what you were trying to achieve, and then obviously the findings and then the practical applications of that to people out there experiencing back pain, or perhaps the practitioner working with back pain patients. So the why behind the what?
Yeah. So the why is, as we mentioned, back pain is a huge problem. So I kind of wanted to be involved in that space to try and help as many people as we can. And then the second thing was, there's, as we've mentioned, there's so many beliefs around movement and posture, and you've got to keep your back straight and brace your core and sit up tall, and so many rules around there, which actually aren't that evidence-based. And when we look at a population of people with low back pain and we actually measure how they move and how they sit and stand and how they bend and lift, and we compare that to a population that doesn't have low back pain, we actually find that these people move more like the rules. So they adopt these postures, and that's a chicken or the egg scenario, but they follow those rules more than people without low back pain, that people that just go through life not having a problem. Sometimes there's a sort of a saying that you can spot the person with back pain because they've got the best posture, and I put best posture in quotation marks. They're always sitting up straight and they're following all those rules. We know that there's this big problem, and a lot of those postural rules around sitting up straight and bracing your core, and look, they're not bad rules in and of themselves, but they can perpetuate a narrative of vulnerability and, caution, and, your back's fragile and be careful. They come from a much more preventative space. There's not much evidence that they're very helpful for prevention. But what I was really interested in, we've got this, call it an epidemic of low back pain. What happens when people get better? Does their movement and posture improve, quote unquote improve? Does that get better? Does that change? Or is their improvement completely irrespective of whether their movement and posture actually changed after they had an intervention? So that's the lens I was really going through the PhD with, was understanding over time, so a longitudinal relationship. These people with low back pain, we know we've got this population. We know that they tend to move more cautiously. They tend to be more guarded, have more trunk muscle activity, move slower, move less, are much more careful. Usually associated with damaged beliefs, and we know that emotions influence that too. Emotions influence tension and the amount that people will bend to pick something up and complete tasks. But what happens to those people's movement and posture and their psychological factors as they actually improve? So my PhD was broken up into 4 aspects. And this was a mixed methods PhD, so I wanted to understand it from a quantitative perspective, so looking hard at the data and the numbers, and the existing literature, but also I did qualitative interviews with participants and with their treating therapists as well, to really understand from their perspective, what's your experience? That's a really useful way to understand a phenomenon, is to actually ask the person that's experiencing it from a qualitative perspective. So it was a mixed methods PhD, but it was broken into 4 papers that have been published out of that, and there's a few more in the pipeline on the go. But broadly speaking, broken up into 2 systematic reviews, a single case series where we had 12 people with disabling low back pain, and tracked their movement and posture over time as they improved, and then a mixed methods paper, which was published this year in the European Journal of Pain. That's an open access paper that looked at people's experiences and conceptualizations of how movement and posture changed, but also looking at things like their psychological factors and the change in those things and how they related as well.
Yeah, I mean, well done on all the output. It's so enriching for clinicians out in the field, such as myself. I think it gives us some really great tools and a sense of evidence base with the observations that I've seen over time, which is when people just learn to live with it, be de-threatened, have their experience de-threatened, educate, give them tools of just getting back into exercise. Like you said, it doesn't seem to matter what type of exercise that may be, that they get better with time. But this work of yours, Kevin, I think really can tell us some of the reasons why that is. So you talk about going on this journey from your mixed methods paper has a beautiful diagram in here. The journey from pain and protection to non-protection and just living. It's a beautiful little infographic, and I know you've shared this on your Instagram page. Can you just sort of talk us through this infographic, protection to non-protection and just living?
Yeah, awesome. I'm glad you like that one. That's probably one of my favourite outputs from the PhD as well. So broadly speaking, this paper was based off the journey from 12 people. These people had disabling low back pain. We recruited them because they had high levels of pain, and a lot of them weren't working. They had tried surgery on workers' compensation, tried medication, injections, previous physios. A lot of high intervention. To give some context of how disabled they were, or how impactful their pain was, their average Roland Morris was 17 and a half. Sorry, their median Roland Morris was 17 and a half out of 23. Most studies that I looked at in my PhD in the systematic review that we included, which were back pain trials, so randomized controlled trials, they were around 5, 6, 7 out of 24, and higher is worse on that scale. So these are the more disabled end of the scale from a back perspective. And so we interviewed them at the start while they were having their low back pain. We also measured their movements and postures on a weekly occasion using wearable sensors and EMG, trunk muscle EMG, measuring their specific problems the specific tasks that they had problems with. So we asked them, what are the most bothersome things based off the patient-specific functional scale? They might say bending, sitting, standing. Then we measure bending, sitting, and standing on a weekly occasion for 5 weeks without any intervention. That's when I did the interview. And we could just track how they performed these tasks that they found value in really trying to be in a very natural environment, because the wearable sensors don't obtrude much at all. We also collected pain and activity limitation or functional outcomes, as well as a whole bunch of psychological factors. So things like pain self-efficacy, pain catastrophizing, pain control, back pain beliefs, pain perceptions, those sorts of different things on that same weekly occasion. And then they had a 12-week cognitive functional therapy intervention. And then we measured all those factors again for another 5 weeks after they had that. And I did another interview, and that's what formed that follow-up period. So that sort of frames the study. When we were analysing the qualitative interviews, so you have all the transcripts and you're analysing and looking for themes, we really found these themes of protection during those baseline interviews, so those first interviews. And this wasn't necessarily just conscious protection, but it was also the participants described these lived experiences of feeling tense and stiff and guarded and locked up and seized up, and all this stuff our patients really say when you ask them to describe their pain. So that we've dubbed that as nonconscious protection. So it's sort of a subconscious, automatic, habitual protection tension that their body just does. And usually that's because of a number of things, but pain being one of those. Pain makes you tense, but predominantly beliefs around damage or something being wrong in their back. We also heard stories of people saying, no, I have to purposefully protect my back. I'm braced, I tense my core, I keep my back straight, I'm careful and I'm cautious. And that again was driven by this belief of damage or vulnerability in their back, or something being wrong, or just the future and being uncertain around that, or uncertain around the diagnosis. So in that baseline period, broken up protection, but broken up into non-conscious protection as well as conscious protection. And then they had the intervention. Yeah, sorry.
Oh, just to clarify there, Kevin, so non-conscious protection, I know your paper cites a few comments made by the study participants, such as obviously they're nameless, but it's my back's always in protection mode, protecting whatever is wrong. So that's an example of a statement relating to this non-conscious protection. And then conscious protection was one of the participants saying, I have to be careful about everything I do and how I do everything. And it's that conscious seeking to, I guess, seemingly protect their back.
Yeah. Yeah, absolutely. And thank you for bringing those up. I think that's, and this paper is, as I mentioned, open access. So I really implore everyone, if they've got the time or they're interested, to well, at least look at the infographic, but the way that it's been written, we incorporate or embed those quotes so that we're really hearing those patient stories as part of those themes. And I don't think nothing's as powerful as patient stories and quotes. You just kind of get it. And exactly like you've described there, they really summarize those themes.
Yeah, it makes for a much more compelling science read. That's for sure. It puts the humanity in it.
Yeah.
So sorry, Kevin. You carry on. I just thought it might help those and just get a bit more scope around this non-conscious and conscious protection type thing.
Yeah. You can pick a few of your favorites for the next ones as well if you want.
I mean, you're one.
So then they moved. Then they had the intervention, 12 weeks, and then I interviewed them again. And the first thing that really came out of it was these participants talking around themselves, finding that purposefully relaxing and breathing and moving more normally was associated or resulted in a reduction in their pain and an increase in their function. So they could start doing things that they previously valued or couldn't do with less pain. But this came about because they were now relaxing, breathing, using breathing to relax and moving more normally. We've dubbed this conscious non-protection. So they're now no longer protecting, or they're protecting less, but they have to consciously think about protecting less. So conscious non-protection.
And should we throw in one?
Yeah, let's do it.
Participants doing everything opposite to the way that you're told to do it feels better, way better. And then this one, I thought I was stuck with it for life. So the fact that it's been as simple as just changing a few of my movements and, looking at my sort of levels of tension, I can't believe that was all I had to do all along. What it was basically my own kind of the onset of pain was probably caused by what I was doing as opposed to something failing in my body. Isn't that just beautiful?
Yeah, it summarizes it nicely. And look, it's not always that simple. I mean, these were treated by highly, highly trained clinicians that had undergone lots of specialized training of cognitive functional therapy. And it was a theme that people talked about it being, like I didn't realize it was this simple. I feel a bit jaded almost that all this time I've been told to brace and suck my belly into my spine and make sure I contract before I move. And all I had to do was actually the opposite of that, or, those sorts of messages. They kind of felt almost a bit jaded and that it was, they liked that it was simple, obviously, but it isn't always that simple for everyone. And there was one participant that really didn't shift that much, which we can talk about. But yeah, that kind of summarizes that conscious non-protection.
So there was an awakening from following the rules, which didn't necessarily confer a good outcome, to forgetting the rules and therefore feeling a bit jaded that it didn't actually take a lot of ongoing effort and work.
Exactly. Yeah, exactly. And often that's something that I'll mention to patients as they walk out is like, go and break some rules. Let's break some rules. Let's see what happens. And I think that speaks to an important point here is that these experiences were just that. They were experiences. They came about because skilled professional or skilled physios were taking them through a guided behavioral experiment, and they had experiences that disconfirmed their previous beliefs of damage. It wasn't just a case of your back's fine, bend and breathe, move normally, you'll be right. Because that's just not the way that the brain and pain works. It's a bit more complex than that. These are really ingrained beliefs. So yeah, important to mention that it's not always an easy journey, and we're always consistently learning. But these came about through guided behavioral experiments and really useful, good, personalized education backed up by evidence. And we can't deny that there's an effective research here as well. That these participants were part of a research trial. It was, and I should mention this, this research was funded by a Physiotherapy Research Foundation grant from the Australian Physio Association, and as well as I was supported through an Australian government research scholarship. But these people weren't paying for their treatment. They were part of a research study. I was interviewing them, I was following up with them and collecting measures with them every week. So there is factors here that are not typical of your clinic environment, which may have worked in our favour, may not have. We can't really measure that. It's hard to do, but important to consider. But yeah, the take home there is that it's not always simple, but certainly a lot of the participants in this group talked about that it was that breaking of the rules.
Yeah, no, well, some great context there, Kevin. And then on to non-conscious, non-protection.
Yeah, so in that first group, there was 4 participants that were really strong in that, and we sort of tried to put them into those categories in their follow-up interviews. And then I kind of like to think of this as a graduation from conscious non-protection all the way into non-conscious non-protection. So these people had just forgotten about their back and just returned back to living. So back to automatic, natural, relaxed, fluid, free movements and postures. And as I mentioned, this was secondary to positive experiences that disconfirmed or violated their previous beliefs, usually of damage, as well as individualized education about their condition, about their scan findings, and about the meaning of pain. So most people kind of graduated or progressed to that, or were in that category at that follow-up period. Would you like to talk about your favorite quote in that area? And there's loads more quotes in the appendix, a few that are a bit more vulgar than that. So yeah, there's plenty of examples of these.
But 2 of those examples, Kevin, one is before I'd be bending my knees, keeping my back straight, trying to pick up correctly. Now I don't give an F.
Yeah.
Don't think about it. I just do it. And another participant said before it was a lot more of, there was lots of thought that went into that bend. And it's like, can I actually do this? Is it going to hurt? Just be careful. Whereas now it's just automatic. I bend, I pick it up, I pick up, I come up. That's good. I'm certainly not moving like a grandma anymore. I can move a lot faster, which is nice. It's really, really good to feel like I can move. I don't have to think about it. I don't, in fact. I think I'm at the point where I generally don't give it a lot of thought. I tend to just do. So that's that non-conscious, non-protection. You said that they've forgotten about their back and they've returned to normal living.
Yeah, exactly. And I think that's our ultimate goal as therapists. If I injure my wrist and it gets better, I don't really think about my wrist anymore. And I've fractured, I can't remember which arms that I've fractured, both of them at some stages, elbows, ankles, and I can't remember. Often I forget which one that is broken. And I think that's a really good place to be. We don't want to be thinking about our previous injuries. They probably hold us back if we're still thinking about those. Obviously, you want to be mindful of those and working on certain things if there is things to work on. But I think the gold standard of what we aim for is what we call a forgotten joint. You just forget about your back. You forget you even have a back. And this is sort of a scale that was done by an orthopedic surgeon out of Western Australia. The gold standard for a knee replacement is that you forget you have a knee. So they developed this forgotten joint scale. And maybe another thing to talk about is that this model is a little bit similar to the conscious competence model of learning, where initially you're non-consciously incompetent. You're not aware that you're incompetent. Then you're consciously incompetent. So you're aware that you're incompetent. And then you eventually go to consciously competent. So you've got to work on a skill consciously, but you kind of know that you've got it. And then eventually you're non-consciously competent. So you've just got it automatically. So it was quite nice to see that literature from a sort of education perspective as well.
Yeah, I think many people recognize that learning paradigm. I think as a clinician, somehow 16 years in, I'm still consciously incompetent.
Absolutely. Yeah. No, we're always learning.
Gosh. All right. Brilliant. So that was some great, so we're on this journey from dealing with back pain and from protection to non-protection, just living. Kevin, you did mention that there was one participant that was an outlier who, in simple terms, didn't get better. Can you share a little bit more around that participant's journey in the context of that?
Yes, this participant was our oldest participant. I think she was 76. And yeah, she didn't really have a sustained or meaningful improvement in her symptoms. During the sessions, she would experience pain relief or less pain or some element of pain control doing her specific tasks. I think off memory, they were things like standing and sustained bending. So she would have these experiences of, okay, relaxation or more normal patterns during those did feel better, but she really struggled to integrate that into her own daily life. She also talked about this idea of relaxing felt really counter to what she's been told and lived by her whole life. So she's got a long sort of period where she's always believed that this is important, is to sit up straight, keep your back tense. And she sort of, there's a quote in there as well. Physically, she felt better when she relaxed, as in her back pain reduced, but psychologically, it just didn't sit well with her. So that was one element of that. There was a number of other factors going on for her. She had quite a traumatic early life, and we know that early life adverse childhood events are really quite strong predictors of who's going to have future pain. But in the same breath, her pain had only developed within the last kind of couple of years. So she's a complex presentation. We don't have all the answers, as is often the case. And I don't know how she's going now. I probably should follow up. It would be quite interesting. We do have some long-term follow-up data, and she did improve in some areas, but not really to the same degree that everyone else did. Everyone else had these big, strong shifts. She had a few little smaller shifts in things like pain control and function, but nothing really large and sustainable. So I think it's really interesting to have those different outliers. We had another lady who moved actually quite normally to begin with, quote unquote normally. She moved like everyone did at the start, but still had pain at the start. And she had a big improvement as well, but she was also quite a complex presentation off work on a kind of temporary visa and struggling to find work and a challenging home environment and those sorts of different things. So it speaks to the complexity of pain, and we can't help everyone. We certainly can try, and we should try. But there are people that for whatever reason their patterns are very ingrained. Their nervous system is in a state where it needs to protect. And it decides that that's the most important outcome of whatever stuff has gone on for them.
And practically, other than observing that perhaps they're not trending in the direction that would be desired, i.e. a good outcome, are there any tools, Kevin, for the therapists or clinicians or practitioners out there, outcome measures, assessment-based protocols that you'd recommend to keep an eye on for such for such people as you've just mentioned there?
Yeah, so absolutely. Still validating them, I think, is so important. But there's questionnaires like the ACEs questionnaire, Adverse Childhood Event or Experiences questionnaire, even things like your Central Sensitization Inventory might be another outcome measure that you could consider there. I think the low back pain beliefs, or the back pain attitudes questionnaire is a useful one to identify damaged beliefs, and which sort of brings me back to that participant one as well. She maintained damaged beliefs. So a lot of these people, their damaged beliefs really shifted because they had these really positive and powerful experiences that said, well, okay, my back's no longer damaged because I'm bending more and I'm moving more and it's hurting less. So that throws out the window my worry about damage. But this person, one of her quotes was, to me, it's just that I've done some damage there, and to just do the normal thing, I'm at a disadvantage because my back doesn't like it. Until it's repaired, it's not going to give me less pain. So a maintenance of those damaged beliefs. Yeah,
that makes sense. And I think for the practitioners listening, most practitioners at some point have possibly had a patient for whatever reason hanging out for a surgical intervention, which of course, as practitioners, we are not anti-surgery. There is absolute indications for that at times.
Absolutely.
But I've found it clinically for certain patients, that can be a real, sometimes feeling of immovable mountain to try and get through when someone just believes that the only thing that will help them, improve them, is surgery.
Yeah, I think it's a really important point. We're certainly not anti-surgery. Surgery has saved numerous lives and helped people with pain all over the world. In the right people, it's really important that it gets done. The hard bit is identifying who the right person is. In those people that have those really strong beliefs, I think we can't counteract their beliefs with information. We have to do it through experience if we can. So, if you're countering someone's beliefs with your beliefs or your understanding of the evidence, that will usually backfire and make their beliefs stronger. It's like if you've got someone who believes the world is flat and you provide evidence that the world is not flat, it's called a backfire effect, and they will just get a stronger belief that the world is in fact flat, and they'll find flaws in your argument. So by that I mean taking people through experiences where their experience disconfirms their belief. People don't argue with their data, and then you can let them come to the conclusion. Maybe a practical example of this is if someone's like, well, my disc bulge is causing my back pain, and I need surgery on my disc bulge. Rather than saying, here's this Brunjiki study 2015 with all the systematic review findings of all the normal of disc bulges being in people with asymptomatic with no pain. Understanding, okay, so what's your understanding? Why do you think that? Or has someone told you that, or have you figured that out for yourself? That every time you bend forward, your back's going to bend, your disc is going to bulge. Oh yeah, no. The guy at the gym told me that, as I bend forward, and then it pushes the disc material out the back and causes it to bulge, and I could be a paraplegic if that happens. Like, oh wow, that's quite frightening. Can you tell me about some of the positions that feel really good for you? It's like, I'm making this up, but maybe they say like child's pose or bringing my knees to my chest in my back. It's like, oh, that's interesting because that's actually a flex position for your back. So how do you make sense of that? Oh, yeah, you're right. Actually, that is a really comfortable position for me. And then it's like, well, sometimes, people can just adopt these postures, and because they're really painful, or they have historically been really painful, it can be quite a frightening experience. And people's body just adopts these funky patterns. Like, what happens? What do you think will happen if you bend forward? And he's like, well, yeah, maybe my disc will bulge out the back. And it's like, how confident are you of that? And they might be 10 out of 10 confident, in which case you've got to really bridge that gap quite slowly. Or you might try a behavioral experiment, or you might assess them bending and they're holding their breath, they're bracing, they're trying to keep their back straight so it doesn't bulge. And through a series of behavioral experiments and teaching them how to relax and assessing them and identifying and highlighting to them, hey, do you realize that you're really tense as you're doing this? They might realize, oh yeah, actually I am really tense. I'm holding my breath. And what would happen if you were to relax and try to bend normally? And you might do this in seated position first, or an unloaded position first. Like, it's a graduated process if they're really, really fearful. They might after a while start realizing, hey, actually this is starting to feel a bit better. And then you might say, well, why does it feel better now compared to before? I mean, I haven't done anything to your disc bulge. What's different about the way that you're doing it now? Oh, well, you told me that I can relax, and I didn't realize I was holding my breath every time and I was braced. It's like, okay, so you're feeling better now. What does that tell you about what's causing your pain? It's like, well, maybe it's more to do with the way that I'm moving and the way that I'm bracing and protecting my perceived bulging disc, rather than the bulging disc being the source of pain in and of itself. Because that's, if the pain shifts that quickly, the injuries don't heal that quickly, and probably this person's had it for a long period of time, so their injury would have healed anyway by that 3-month period. So it's not as simple as just saying, confronting that belief with evidence, especially if it's really strong. Or I might ask for it if they just want, just tell me what to do, or tell me your opinion, then I might say it. But like I said, people don't argue with their own data, and if they've got a really strong belief of surgery or of something, then you can't really, you try to counter that, and you often encounter a backfire effect.
Yeah, gosh, there's so much you shared there, Kevin, but it's pertinent and really well articulated. I've heard it said that the person with data is at the mercy of the person with the experience, the learned experience. And it's just, I think about my own back pain, frightening, terrifying actually at the time,
Totally.
It was terrifying because it was threatening to me as an active 23-year-old male who wanted to surf and finish my university degree and go to the gym. And I often think back and do tell patients in the consult room these days, I would have done anything for someone to have sat me down at the time and offered me some reassurance and perspective and helped me work through my fears and beliefs. At the time, that wasn't available where I lived. And so I sort of bounced for the next few years trying to piece it together myself, and slowly with a diminishing sense of fear and threat. And I'm many years down the track from that now, and I haven't had back pain for 15 years because I don't even think about it. And what you just shared is so key, and I think invaluable. So thank you for taking us there. Kevin, this is a challenging question, but what would be your top 3 messages to the person out there, the listener currently experiencing lower back pain that is feeling a sense of unease about the impact of it on their function, daily life, and perhaps their future?
Yeah, absolutely. So it's a really tough problem or space that they're in. And I'll just touch on your kind of experience just briefly as well, if I can. I think that's for someone to sit you down and reassure you, that takes time. And, we're not in an industry, and this is a deeper conversation, but we're not in an industry that rewards people spending extra time but getting a better outcome. It's a service industry. We get paid every time we see someone. So in a weird way, we're almost incentivized to keep seeing them, I suppose. And so there's lots of different challenges. I know GPs are under incredible time pressures to see people for a long period of time, and they've got medico-legal challenges as well. So there's a multiple number of different factors that are influencing these processes, and really at the end of the day, I think what we're trying to do is do good by our patients, and I truly think that most people out there are trying to do that with the resources and the education and the skills that they have. So I just thought I'd kind of round off on that. In terms of the number one tip that I'd have for someone in pain, it would be that asking that question of, could there be more to pain than what I think is damaged? I think that's the first question to ask themselves. Some practical stuff. Learn more about pain neuroscience. There's some great resources, and I'm happy to share a list of links to infographics, to podcasts, to books that I would encourage people, if they've got persistent pain, and we're talking about persistent pain here, that is non-specific and not caused by cancer or some malignancy or something like that. Learn more about pain. Your pain, it's highly unlikely that you're as damaged as what you think you are. This is general advice. Obviously, consult your health professional. This is general advice only, but it's highly unlikely you're as damaged as what you think you are, what you've been told you are, or what your scan says you are or might be. That damage might not even be relevant, quote unquote damage might not even be relevant for you. And look after your whole health. I know you said one tip, so maybe I'll stop there, but look after your whole health. Oh, 3 tips. Okay, good. Look after your whole health. Pain is multifactorial. There are many factors that contribute to pain. That also means there are many factors that levers and stuff we can pull to try and reduce your pain. So looking after sleep, looking after stress levels, looking after physical activity levels, nutrition levels, even the time that things like time restricted eating influence your inflammatory levels and the inflammatory profile. So a variety of different things. Find time to relax and do things that you enjoy.
Yeah, gosh, some great tips and takeaways there, Kevin. I'll just quickly recap. Ask yourself, this is for the individual experiencing lower back pain at the moment. Ask yourself the question, could there be more to their pain, my pain, than what I think is damaged? Secondly, learn more about pain science, and you're going to share generously some great resources, which we'll attach to the show notes over at physicalperformanceshow.com. Obviously, following yourself on socials, a great resource as well. Kevin Wernli Physio over on Instagram. And then look after the individual's whole health. So there's other factors at play here, like you said, sleep, stress, nutrition perhaps, etc. What about for the practitioner out in the field, Kevin? Your top 3 tips for the practitioner working with patients with lower back pain?
Yeah, I think we've touched on a few of these today. I think one of them is listen. If you've got the time and you can afford the time, listen. I think there's a statistic that GPs will interrupt their patients within the first 10 seconds, pretty much all the time. I think that's probably true of physiotherapists as well. And I really try to bite my lip in that first minute and just let them tell their story, because there will be something that is of absolute gold come out in that time that's really valuable to them. So, if I asked you, tell me your story, Brad, with your back pain, you would have said, oh, look, I really want to surf and be fit. And it's like, right, that's a key thing for you. It's not like, oh, the pain started here, the pain's this intensity or whatever it is. It's like, that is your goal, that's your identity. Try to zip your mouth in that first minute, because something gold will come out of it. So that'll be the first tip. I think number 2 would be, educate with experience, not with lecturing. If you can, that's a skill to learn. Motivational interviewing and reflective questioning and behavioural experiments and those sorts of things. But like I mentioned, people don't argue with their own data. And the third one would be mind your language. So the amount of times that patients will come in and say, oh, my doctor said it's bone on bone, or the doctor said this, or the physio said this, or the chiro said this, or whatever, people will take 1 or 2 key messages from an appointment, and this is why we need some regular follow-up with people to support them, because there's so much that can happen in an appointment, and people on average will remember 3 or 4 key things, and it's usually not the stuff you want them to remember, and it's often the stuff that you might have said, there might have been a slip of the tongue, or you might have not quite said appropriately or correctly, but it's been interpreted in a way. And we might bag other health professionals out when we hear patients say, oh yeah, the doctor said it's bone on bone. It's like, oh, that doctor, that's annoying. But realistically, we weren't there. We don't know exactly what the doctor said. That might be just what the patients heard, because it's frightening for them, and that's what they've understood, and they've seen a scan or whatever. So we never really know what happens in that clinical encounter. And often there's been some qualitative research in this, and often there's a lot of Chinese whispers by the time it actually gets to you. So everyone, I think all health professionals, like I mentioned, are doing the best with the tools that they've got. But I would say be mindful of your language, because the people that you see that come to see you, they usually have a lot of trust in you to come and see you. So that's a very powerful tool.
Gosh, some top tips there. Number 1 tip for the practitioner in the field: listen, let the patient, the individual, the athlete tell their story. 2, educate with experience, not with lecturing. And 3, be mindful of your language. It's so powerful. Kevin, there are hours of conversation that we could engage in around this topic. I feel like in many ways we've scratched the surface, but hopefully there's been some great learnings to be had there for those listening in. Just a couple of quick questions, if we may. I heard in your little 3-minute PhD thesis video that's on your Facebook page, I think a key statistic that would jump out to many people listening in, and that is that there's a poor correlation between disc protrusions and pain, and that 80% of the time disc protrusions naturally resolve. Anything you'd sort of add to that? That was obviously a quick statement in your 3-minute summary.
Yeah, of course. So, and this speaks to imaging findings. And we know that, look, imaging is a really important thing. It's advanced so far, and it's really important in a subset of population, a subset of people with any musculoskeletal pain, and certainly low back pain. But it is probably overprescribed, and people are quite quick to jump to imaging, and that usually results, if it's not appropriate imaging, can result and often results in actually a worse outcome, what we call an iatrogenic effect. So your healthcare system has induced a worse outcome than what would have occurred if you just didn't get the imaging in the first place. But that statistic speaks to a couple of things. The first is how common things like disc protrusions and disc degeneration and disc bulges are in people with no pain. Some quick statistics here. If we were to scan 150-year-olds, 80% of them will show some disc degeneration. 60% will show disc bulges and 36% will show a disc protrusion. This is in people with no pain whatsoever. And if we look at people that are even older, 80-year-olds, 96% will have a disc degeneration, 84% disc bulge, and 43% a disc protrusion. So these factors increase as we get older. That's a little bit like grey hairs and wrinkles increase as we get older. Some people get them younger, some people don't get them really. It's an indicator of aging, and some of these findings are indications of aging, painless indications of aging often. They can be painful, and that's our job, is to figure out, well, has there been enough trauma here to cause an injury? And then the second aspect of that is that most people don't know that a disc bulge will heal. And heal is probably not the right word, but resorb back into the spinal canal or spinal cavity where it should be. Most people, when they have a scan from 20 years ago or longer or 5 years ago, they'll still be that scan. Their identity will still be that scan. So they got a scan that said disc bulge when I was 32 years old and I'm now 60. They'll still identify that they have a disc bulge at 60 years old. But we know that the majority, within a few months, certainly a year or two, that statistic was 83% resorb. And if you were to scan them again, they wouldn't have a disc bulge anymore. So they might believe they have a disc bulge and their identity is they've got a disc bulge, but actually the disc has resorbed back to its original spot. And their pain, albeit still very real and in the same spot and the same location and very convincing, but is driven by other mechanisms, by this complex neural circuitry, if you like. And we know that the quote unquote worse the disc protrusion is, the more there is protrusion, the more sequestration there is, the better it resorbs. And they think that's due to because there's more of an inflammatory response. And there's more kind of tissue healing warriors, fighters in that area to resorb that disc material back to where it came from. So, yeah.
Gosh, for those that do have a diagnosed frank disc protrusion or event, I think that's very reassuring and powerful. And I guess it comes back to that, ask yourself the question, with persisting pain, could there be more to someone's pain experience and what they think is damaged? As you've just said, 83% of these disc protrusion events will resorb. Kevin, is there anything you'd say specifically to the young person? Like you said, we know that at 50 years of age, we'd expect X amount of the population asymptomatic without pain to have image findings. But the young person, there's often this belief that if you develop pain young in life, I was 23, that I've now got a life doomed to living with back pain and disability.
Yeah. So couple of things. That's only with back pain. If you develop wrist pain or neck pain or knee pain, maybe neck pain is a little bit different, but certainly knee pain or ankle pain, you don't have those thoughts. So it's only really back pain that have those thoughts around doom. And we talked about that right at the start of this conversation and that associated threat and those sorts of things. But the study that I was referencing there was a big systematic review, which is a type of study where you're looking at all the existing literature that's done in the world on a certain topic and you're synthesizing it. And I did 2 of these in my PhD. This is not one of mine. This was done by an author called Brinjikji in 2015, looking at the age-specific prevalence estimates of degenerative spine imaging findings in asymptomatic patients, people that have no pain. And if we look at the 20-year-old, 37% of those will still have disc degeneration. 30% will still have a disc bulge and a disc protrusion. So it's sorry, young people, but you don't escape this label either. But it actually doesn't matter because it might not mean that much anyway. So the messages would be quite similar to young people. And I think they probably maybe they're in a better position because they haven't had a chance for those, neuroplastic nervous system driven processes to really bed deep into their nervous system. And they've got lots of capacity to change, but that doesn't mean you can't change if you're older as well.
Gosh, I like Ebony Rio's adage that every cell's capable of adapting in the body until death. So we are remarkably bioplastic.
Absolutely.
Kevin, and what about the athlete? Oftentimes I hear athletic individuals or athletes of varying levels of performance sort of be a little bit stunned, like, I'm so fit, why have I developed back pain? And my answer is often, well, because you've got a pulse, you're alive. And, then I'll try and share examples, not of individuals necessarily, but of, the people they'd perceive as the fittest on the planet who have had back pain as an example to try and normalize their experience. But what would you say to the fit individual that's shocked that they've developed back pain because they've done years of core conditioning?
Yeah, absolutely. And I should preface, I don't work exclusively with elite athletes. I have worked with elite athletes in the past, but my caseload and research is predominantly in your persistent pain individuals that aren't elite athletes. But similar principles would apply. Why have they got pain? I mean, there's so many things that predict pain stronger than physical things like we've talked about with disc abnormalities and structural issues. So we talked about early life experiences or adverse childhood experiences. Poor sleep is a really big predictor of pain. There was a big longitudinal cohort that tracked people's sleep. I think there were soccer athletes, and those that slept more than 8 hours were 1.7, I think, times less likely to develop pain or an injury in that season than the people that slept less than 8 hours. So they broke that up into more than 8 and less than 8 and looked at the different risk ratios or odds ratios. And then as well as comparing, a different study compared the hours of sleep, and there was a relationship between the risk of injury. That's because, when we're deprived of sleep, and I'm sure most of the listeners could relate to this, that's when they're more likely to get headaches and other body aches. Your tissues don't recover as well. Sleep's this emotional and physical recovery agent. So if you don't have that, you could influence the recovery system. Athletes sometimes are under quite high stress levels to perform, to do well, and higher stress. And if if they have back pain, it's probably even more threatening to their livelihood and their lifestyle. And their ability to earn a living and to meet contract regulations and requirements. So it can be a much higher threat to someone, and therefore their pain system will really want to alert them and therefore amplify that pain through a variety of different processes occurring in your periphery and in your central nervous system. So that would be the things that I would be looking into for an athlete. And as you said, reassurance is really important. And sometimes it is just about being with them, supporting them and hanging in there. The passage of time is an incredible thing.
Yeah, the passage of time. Kevin, you've been so very generous with your time and sharing of your knowledge. So we do thank you. I think we may have to, down some stage down the track, have Dr. Kevin back on for a Q&A. I think that would be a very popular session. But 2 final set questions that we ask every guest of the show, Kevin. The first is, if you could boil everything you've learnt to date into one piece of advice, and we might keep it contextualized to the topic of this discussion, lower back pain, what would Dr. Kevin Wernli's single piece of advice be to the back pain sufferer?
It's more complicated than you think, but learning about pain might just be your ticket out of here.
Oof. Wow. And finally, Kevin, every guest issues the listener with a physical challenge for the week. So what is Dr. Kevin Wernli's physical challenge going to be to the listener?
I think we'll try to make it specific to the individual listener. So choose something you're a little bit frightened of, and try and do that in a mindful, normal, calm, relaxed way. Something that you think might be dangerous or cause an injury for you. And see whether you can disconfirm your own expectations and beliefs. We won't go into it. Maybe that's a conversation for another time. But short answer is we want to try and graduate people towards doing all the things that they thought they shouldn't do or couldn't do or have been told not to do, because there's no better way to get back to living than to tick off all the things that you have been told you can't do, but you're able to do them. So you can either start at the most scary end and unlock everything if you have success with that, or you can start, which is probably more advised, at the less scary end of things. So write down a list of things you've been told you shouldn't do or can't do or have had pain in the past doing, and try to do that in a comfortable, mindful, progressive way. And you might be able to tick a few more things off that list.
And that was specific to the back pain sufferer, Kevin. So it could start with bending forwards and tying up your shoelaces without thinking, straightening your back, for example.
Yeah, absolutely. Yep.
So breaking the rules can get you ahead in life.
Absolutely.
Kevin, you've been amazing. And for those that want to follow your output more closely, where's the best place for them to go? Obviously, we'll tag up yourself and put some of your resources in the show notes, but where should people head to, Kevin?
Yeah, I'm not as active as I used to be, but I still try to post relatively regularly on the socials at Kevin Wernli Physio. That's all the socials: Twitter, LinkedIn, Facebook, Instagram, and that's probably the best place to go, I reckon.
And you're mixing or combining your research interests with your in-clinic work at...
So work consulting at West Coast Health and High Performance out of the Eagles training facility in Lathlane, and at Star Physio in Mosman Park, and also working on a few other research projects in endometriosis and digital health, mental health space as well. So wearing a few hats.
Good on you.
Loving it.
You are a fresh and welcome addition to the integrating research into clinical practice landscape, Kevin. So I've personally learned a lot. So thank you for your contribution to the show.
My pleasure. Thanks for having me, Brad.